Next, we have the most very coveted talk of the session. It's a keynote address by Dr. ROHIT SAXENA on face-to-face with functional visual loss, unforgettable lessons from my experience.
So, thank you very much for the opportunity to be here. And a keynote experiences. These are all shared experiences. Nina's given some very nice tips, and these are, I think, all our common experiences. So I'll just run through some of the things that we have come across, and we've talked about a lot of these which could present as functional vision loss, and as has been discussed, it could be because of a monetary benefit. Sometimes it could be just unintentional, and often in children it's just the pressure of the stress or an exam or avoiding or a situation or trying to get away from some person or an environment. So as has been mentioned before by Dr. Nina, you can't be judgmental about anybody or any behavior, and you need to actually work with them. The presentations can be unilateral or bilateral, severe loss of vision or just mild blurring or just even field effects, and the patient may just refuse to say that I'm not able to see a particular place. And it sometimes may be associated with a lot of other physical changes or physical activities like blepharospasm. Some kids can simulate all kinds of strabismus, nystagmus. So a lot of presentations are possible. The key thing is to try and find out what is the precipitating event or the stress inducer that the child has. Of course, as has been mentioned before, you must rule out an organic pathology. Actually, it would be unethical to label a patient with some or any pathology as a malingerer, not only because of the fact that you're missing an organic disease, but because it does involve some amount of social and family pressures, and again, judgmental behavior from adjacents. And in the late they'll start saying कि इसके दिमाग में कुछ problem है. So those are not kind of identifiers we'd like to have, particularly with children or those who are in a uncomfortable situation. And the aim is to trick the patient into demonstrating some normal visual function. Unfortunately, by the time they've come to us, many of them have been through a lot of the tricks that we have in the armamentarium, and they already know how to trick us with them if they are for a particular benefit. So it's not always easy, and you need to go step by step. So first I'll run through some of the cases that we've had. So this was a 65-year-old retired teacher. In fact, he was one of my earlier teachers. He just came with difficulty in near vision for 1 year. He just was not satisfied with the multiple number of glasses he was using, and the essential thing was that he had been through a lot, progressives and all that. So we also said that, again, must be a refractive error. What else? Nobody's done a great refraction. Let's get him to do a dilated refraction and all that. So we just started to get him read, and we realized he was just shuffling his head a little to try and get an abnormal head posture and read. So his reading was N6, but he was not very comfortable repeatedly changing his head, and he kept saying that I'm a little uncomfortable with my glasses. This was his fundus, and again, he was about 70 or so, was labeled normal earlier. So again, what do you say? Always referred to as a difficult patient, and as is the want at least in our center, and I'm sure a lot of neuro-ophthalmologists, when they don't know what to do, they think that the neuro-ophthalmologists have nothing else to do with time, and we are going through so many pentacams and OCTs and what have you, and these guys have nothing better to do. They sit and chat with the patient all day, so you might as well discuss what's wrong with the gentleman, and he's a difficult patient, and they'll sort it out. So our visual fields, these are Goldman perimetry. These are actually a confrontation perimeter done and put on paper. So nowadays we don't have Goldman perimetry because we don't have a good perimetrist who can do it. But essentially this is like charting out whatever is seen. So this is what the patient could see, and obviously all this area is gone. So the patient actually had a bitemporal hemianopia. And a lot of neurological and neuro-ophthalmological fields can be picked up by a good confrontation test, and probably that's all you need. And he had a large pituitary macroadenoma, as can be evident by the field. So the important thing to remember is never label a patient as a malingerer or daft or whatever have you. it's very important to actually go into all the issues. A lot of these diseases which have been discussed here have been labeled as functional vision loss, a lot of them being maculopathies. We have these small kids coming to us with, or young kids about in their early teens who come to us with mild temporal pallor. Now, it's a constant fight with us, with the retina people, who keep sending us and saying, mild temporal pallor. And I said, no, there's a bit of maculopathy to it. He says, no, it's mild temporal pallor. It's your job. Whatever you want to do with the kid. So in those are the conditions where I would feel a multifocal ERG may have a role to play, where we are picking up these are times of competition, and all children, even mild visual dysfunction would come to us. So early pickup of a heredomacular degeneration may be possible with an MFERG. Of course, after you've ruled out everything else that may be responsible. Now, this was a 25-year-old person who came with working in a private firm, presented with low vision in both eyes for 8 years. He was essentially coming for a disability certificate because he wanted to apply for a government job. He had fairly significant high refractive errors. He was about 2/60, 3/60. He had poor vision with nystagmus. So, again, unfortunately, because people don't know what nystagmus really is, this is what... I mean, of course, that was not nystagmus, but everything else was normal. His pupils were normal. Obviously, with his vision that he was claiming to be, it was not possible to do fields. We re-refracted, cycloplegic. There was no significant refractive error. But again, there was still no significant improvement. We wanted him to get a VER. The pattern, he was just not looking at it. The flash VER was normal. So again, it's easy to fetch a pattern VER. Not easy for a flash, because the light you cannot really avoid if your head is straight. Even if you close your eyes, the flash is usually bright enough to get you an adequate response. But the pattern, easy to fetch. Smart people can just look through, don't look at the pattern, or look a little elsewhere, or just relax, and they're not seeing through that pattern. So it's important to know what investigation to order, because an affected pattern VER, and then you're again struggling and saying that there is some neurological defect in the patient. This patient was definitely, obviously malingering for a clear cause. So you need to put all the story together. He had a reason to do that, and that's why. And again, like I said, the nystagmus, you need to record and see what he was doing. A 13-year-old girl, sudden loss of vision in the right eye, referred as right optic neuritis, received 5 doses, no change, PL positive in one eye, PR inaccurate in the other, everything else normal. Again, the most important thing to pick up: unilateral vision loss, large retinal lesions, and beyond, right up to the chiasma, anything, you are going to have an afferent defect. A pupil is the most sensitive test to pick up optic nerve lesions. Of course, large macular lesions will also be affected, but then you're going to, by that time an RAPD has come up, you'll be able to see a fair amount of changes on the retina. So everything was done in the child, because young girls, sometimes not easy. Everything was normal. Likely malingerer, how do we confirm? Again, we did all our tests first to confront her. We did everything binocularly so that she feels that, yes, I'm seeing through the better eye always. The key test was stereopsis. Often, thankfully, I would say for us, many centers do not, and non-pediatric ophthalmologists do not keep stereo tests. So that's one test the kids or patients are not aware of. So a stereo test is a very helpful test. They think every test that we are doing is being done binocularly, and they're able to know. So when they're able to pick up stereopsis, when we're able to pick up good stereopsis, we know that they were malingering. The patient is malingering. It was discussed, and of course, we got to know that the child was because of exams. This 15-year-old girl, bilateral loss of vision, PL positive, PL negative. The PR kept varying. Every once in a while, some other field would get affected. The pupils, anterior segment, posterior segment was normal. Now, this was the girl. So we brought her to a nice crowded ward that we have. We made her sit, and then we asked the patient's relatives to go, and then we kept on calling her. And that's what you have to observe, what she's up to. And this was her avoiding her bumps. She seemed to nicely navigate through the door, and then the relatives will come and then she starts laying her hands and trying to search for objects. And then you keep the
और जो बच्चे ने सुनाया कि ना मैं मम्मी को सर बोले सुनिए सर बोला कि बच्चा मेरी तो पिटाई कर
गया सब।
discussions
तुमने सारा बता दिया था?
उनको याद करना
फिर क्या हुआ?
possible attention seeking behavior. Suspect when the visual functions are not collaborating with a thorough examination, signs and symptoms are visible. The challenge is to demonstrate one or other normal visual function with objective evidence, and again, not to miss organic causes. More severe and more one-eyed the visual complaint, the easier it is to diagnose a functional vision loss. Again, you have a patient, you can make them wait in the waiting area, just watch them. They're wearing sunglasses in your room because they don't want you to see how they are looking. And these are ways, of course, pupil testing acuity at varying distances. You have a single letter optotype. So the patient is not knowing if it's a subnormal vision, the patient does not know what is the vision I tested earlier. So sometimes if we've had patients who come for medical because of whatever jobs, for UPSC jobs and all, so they know that they need to have 618 vision to get 40% handicap certification, not more, not less. Less, they don't qualify for handicap certification. More, they get ruled out for one or the other particular job. So 618 is a very beautiful cutoff which they have learnt and they have been, taught and fed. So again, do optotypes of single letter optotypes on a screen so that they don't know, and then vary the distance. So you need to trick the patient into not knowing what he is doing. Then stereo acuity, again, varying, has 60 seconds of arc, but at 618. Little unlikely, of course, correspond that with the near vision, but these are tests. Mirror test was talked about. You can even do it unilaterally. Again, as was being mentioned, it's very difficult to avoid. You have a large mirror in front and there is nothing else but just like preferential looking tests for children. It's been devised because it's very difficult for us to not look at an object with structure, with contrast. So every once in a while he'll look away and then come back and look at himself for a second or two and then look away. So these are very, very good tests. Fogging, of course, you have the patient read binocularly and suddenly slip in a high power lens in front of the seeing eye, and if he continues to read and does not, so they'll read a couple of letters and then they realize that something is not correct, and then they'll suddenly stop. So these are, you just need to be and then while he's reading a chart, you put a pen or something in the middle. So if you're reading binocularly, you'll be able to look around and not require head movements. If he's doing head movements just because the pen is in the middle, he's looking at it uniocularly. Otherwise, he's able to look around. One eye is able to look around and still be continue to read. So duochrome test, stereo acuity test, all these are very good ways of picking unilateral vision loss and sometimes bilateral loss also. This was 30-year-old female who was referred with as diagnosed as amblyopia, malingering, sudden loss of vision both eyes, 10 days, significant vision loss, was prescribed glasses outside, not wearing, everything else was normal. You can see suddenly she comes to us, cycloplegic, high hyperopia. So is it ametropic amblyopia? Red flags, recent loss of vision. Obviously, that's not going to happen in ametropic amblyopia. Some pain, the history appeared to be reliable, the pupils were sluggish. When we did an MRI, because nothing was fitting in place, there was enhancement, the MOG was positive. Again, despite the setting being like a malingerer, we still come across pathology. So again, always be careful. Do not overdiagnose malingering. As Dr. Neena said, say you're going to find out an organic cause and then be proved wrong to yourself. You need to have a comprehensive examination. Do not really reveal your suspicions. Notice behavior, personality, posture. Examine the patient separately, not in front of the family, because then they will be on their guard. And obviously have an eyewitness in case of issues in the front, because you can be accused of anything in today's medical legal world. And of course, you need to discuss gradually. You need to discuss with close parents. You may need assistance and help with the psychiatrist or a complete team. Be gentle and of course avoid being confrontational or trying to be very aggressive in your diagnosis, or even telling the parents or associates. So sometimes it's a very catch-22 situation, how much you want to tell the relatives, because sometimes the source of that conversion reaction or the problems may be with the person who's come with the patient. So all these things are very gentle and sometimes really take a lot of time and understanding to try and get the patient to come back to normal or realize that they have normal vision. So thank you very much for the opportunity, and it was a pleasure to be here.
So it was really an eye opener talk by Rohit sir, and such simple things, such seemingly simple things that make a huge difference to our lives and somebody else's too. So this is one area where it is not knowledge that matters, but the way we use it also matters very much. And we have to be sensitive and sensible at the same time in dealing with these complex situations. It's not just medical situation. We may have to extend our helping hand beyond the patient to their families to cope with the person. Usually what happens is our responsibility in getting to the diagnosis itself tires us, but actually the journey of the patient and the family starts there, and it's another journey where we cannot handhold them, but we can always bring in people who can do that. So once you have a functional visual loss, it is your responsibility to diagnose and to refer them to proper people who can handhold them further and counsel them further, so that that is where treatment begins. So we are open to questions. We have 5 to 10 minutes more. So any aspect anybody would like to discuss further, we can always take questions. Okay, then we can yes. Actually, I make my PG, make my PGs do pupil cycle time. I mean, it's not very bad. I mean, we can do it. Can be easily detected. We can do it. Yeah, we don't need to do the entire. We extrapolate. We do for 10 seconds or 20 seconds. Still, it is enough. We can always do the arithmetic. So can we, sir, anything else? So we.
It's great that this was discussed. Functional vision loss is a very and much neglected, and it's as Dr. was talking about, that we handhold and meet. My voice is out now. So it's very important that we gently handhold and transfer them. These are patients who are crying out in need. Their abnormal behavior is a request that somebody please help me. So we've been busy in our OPDs and we see so many patients, and these are actually uncomfortable patients who, it's very easy to be judgmental that you have nothing and you're coming and crowding up my OPD and this is so much of my time. But these are patients really who are telling us that they need our help. But obviously they can't say that to you. And like I said, sometimes it will be a challenge who to tell and how much to tell, because you do not know the background as to why a patient is behaving in a particular manner. And it can be a challenge. We've had children come because they've been pushed into the wrong profession, or they've been pushed to do something which they don't want to, and because of that stress, not consciously, but because of that thing and that need or requirement to rebel against your parents or try to have a different path. So telling this to the parent may actually worsen the situation the child is in. So more than the child, actually it is the parents who require counseling and require better understanding of their children. We are so used to putting in round pegs and square holes that we don't realize that every child, every life is different and to be celebrated as well. So that's what it is. It's sometimes a very big challenge, particularly among children, understanding and trying to be sensitive to their needs. So
I have a question. See, in I think in many Western countries there are like specific protocols as to how to deal with. I mean, who to inform, and like there are like child services and this thing. So, do we have anything like that in the pipeline, or are we, why can't AIOS actually take up something like that? Because I think child abuse is a very under talked about, and it is rampant throughout the country, and I think somebody needs to talk about it and bring it to the light.
It's very nice that we have this functional middle class. I hope next time we have it on child case. It is difficult to pick up, and there is nothing, no guidelines. So it's that's where you are. You don't know the legal aspect where you are, and you do not know what to do for the child. And eventually we are all sending this over to psychiatrists, psychologists to handle it, and they probably would be in a better position to know what to do and how to do and the medical legal aspect of it. But I guess we're practicing in the field, and we are seeing children, particularly possibility of this issue here, there, and time. Yes, more difficult to tell, more complex, and
Happens after surgery also. After cataract surgery, we have had some patients coming from orphanage. They have been enjoying lot of privileges so long. After such a many number of years, we are doing cataract surgery, and then they don't want to lose those privileges because they have good vision. They wouldn't.
possibly good.